The topic is elderly patients with aortic stenosis. And I am with Christopher Maduri, Beth Israel Deaconess Medical Center. And you're doing a study of elderly patients. And one of the first questions always is, how elderly? Just who are the patients, and then why are you doing this study?
Absolutely. No, that's a great question. So elderly, it's not always an easy question to answer, and I'm glad you asked me that right on the spot. But in this study, we're looking at patients anywhere from 70 and over is what we've looked at as one of the factors predicting frailty and classifying different subgroups of frailty in these patients. Anybody over than 70, I think we're classifying here as potentially as an elderly patient.
Why do we need a better risk stratification tool?
So the challenge right now is the current kind of conventional thinking is using the STS risk score to actually predict mortality for patients undergoing aortic valve surgery, which has been reasonably effective in the low and moderate risk patients. But the concern is in these high and extreme risk patients, really the prediction model really doesn't play out that well. So the hope that is if we can improve on a tool that's already pretty good with adding some additional variables, that will better be able to predict these. And the reason will be that now with the advent of percutaneous valve replacement surgery, with TAVI, that there's a different option for these patients. So the thought is if there's a better option for a certain higher risk patient, such as somebody with an STS score of 10 and some of these factors, that maybe they should go under percutaneous therapy instead of surgical aortic valve replacement.
So these were high-volume cardiac surgeons?
Exactly. So this is a study that we've done preparing for the U.S. core valve pivotal trial, and I've been lucky to work with Dr. Jeff Popma, who's been helping guide me through this process. And we surveyed 36 high-volume cardiac surgeons involved in the study. And what we did is we went through the literature and found patients or risk factors that provide incremental mortality in patients that are general surgery patients. A few of these factors were found in cardiac studies, and then also in just elderly patients in general that aren't undergoing surgery, and they were found to actually increase mortality. And so what we did is we took these tools, or these variables, and asked these surgeons how much of an incremental risk of 30-day mortality do you think these are on top of the STS score. And we were pretty impressed by what we found. So we weren't surprised that liver disease is obviously pretty high, but probably not as relevant to some of this information. But we did find is extreme frailty, which we actually left to the definition up to the opinion of the actual surgeons, was a 27% increase in mortality in and of itself. Other things that aren't currently included in the STS risk score, such as elevated PA systolic pressure, porcelain aorta, extreme or hostile mediastinum, and FEV1 less than 750%, all in and of itself increased mortality. Their estimation was greater than 15% without STS. And the reason that's important is because in the STS, or in the core valve trial, a patient with an STS score or predicted mortality of greater than 15% is actually classified as being a person who would be considered TAVI versus surgical AVR.
I mean, here at SCAI, there's a paper on nonagenarians undergoing Tavr.
Exactly.
And so we're talking about an elderly group. It is really nice to know which ones might be safer to do this.
Absolutely, absolutely. Actually, in our center's experience, we've actually had 8 patients of our that are actually over the age of 90 that have had the percutaneous valve replacement and have had remarkable results. One lady's going to have her 100th birthday next year and is still doing quite well.
That is terrific.
And, obviously with the rising health care costs, people have very reasonable concerns is that, is this the right thing to do? But, when you can look at somebody a few years down the road and they're still doing well, I don't think that age is a fair cutoff or a reason to not provide somebody a therapy. So I think this tool not only do that, but also discriminate. Maybe there's some patients that we shouldn't be doing this procedure on too, and hopefully it'll help predict those patients too. So.
Christopher Maduri is my guest. We're at the SCAI meeting. I'm Rick McGuire, CardioSource Interventional News.